Okay. So first of all, I would like to invite Dr. Nirmal. He is a senior consultant, pediatric ophthalmologist. So his case is don't blink, you will miss it.
Thank you, Soumya ma'am. Thank you, KSOS, for giving the opportunity. I am going to talk about a scenario which most of us would be coming across, which is a child with frequent blinking. Okay. The main problem when it comes to examining such children is to get a proper slit lamp examination, especially if the child is very small, apprehensive, it becomes difficult. So the highlight of this case is to listen very closely to the history. Okay. So here we have a 3-year-old girl who has paroxysmal episodes of eye blinking for the last 3 weeks. So the history is like the child starts blinking forcefully, intermittently for some time, and it gradually comes down. It may last for half an hour to 1 hour, or it may go on for a couple of hours, and then gradually it comes down. So by the time they reached us, multiple ophthalmology consultations were done uh, with lubricant eye drops, antibiotic eye drops. Everything had been tried, but the condition persisted. And finally, the last person who saw suspected seizures and referred the child to the pediatric neurologist. So the pediatric neurology perspective, our consultant was suspecting either G1 syndrome, which is an epilepsy with eyelid myoclonia, or a sunflower syndrome. Sunflower syndrome, though rare, it is usually seen when the child goes out into the sun and they have a peculiar hand movement across the face. So that is typical of sunflower syndrome. But somehow our pediatric neurologist was not convinced regarding these paroxysms being seizures and hence was referred to our department. So when we revisited the history, we came to know that there was a history of trauma with a toy, plastic toy, to the left eye a few weeks prior to the onset of these paroxysm of frequent eye blinking. It was treated in a nearby clinic and she was relieved of the redness photophobia in a couple of days' time. Now, when I kept listening to the mother, because most of the time mothers are somehow, while history taking, they seem to be better clinicians than us. So when I kept listening to her, she gave the most important clue and she said, "Sir, this happens most of the time, this happens when she wakes up from her sleep." So that was the major catch in this. So the examination part was quite difficult because the child had already had consultations. It was very apprehensive. All, the routine pediatric ophthalmology, shouting, screaming, everything was happening. But somehow we could do a slit lamp examination. The other evaluations were all normal, except there was a small nebular opacity in the nasal left cornea. There was no refractive error also, and the fundus was normal. So this was how the child was behaving. This is after she wakes up. She keeps doing this for quite some time and then gradually starts opening the eyes. So if you are listening, she is actually telling her mother not to take video. So that is what prompted the neurologist to think this is not a seizure, because the child is well oriented, conscious, responding to everything. So a provisional diagnosis of a recurrent corneal erosion in the left eye was made, and all we did was to give lubricant eye gel and specifically instructed the mother to put it before every time the child goes to sleep. And otherwise the eye was quiet. When I saw the child, there was no redness, no photophobia, no lacrimation, nothing. It was a quiet looking eye. So all we did was give the lubricant eye gel every time the child goes to sleep. And when we reviewed after 1 week, there were no such paroxysms in that 1 week. And so we continued the same for a couple of months and the child became symptom free. So these are the differential diagnosis. First and foremost, definitely we need to rule out any refractive error no matter what the age of the child is. The second most commonly we encounter is the allergic conjunctivitis. Now ticks are becoming more and more common. in our clinical practice where the child comes with frequent forceful blinking of the eyes, and most of them have associated conditions like ADHD also. And intermittent exotropia is like it is closing one eye. The other differential diagnoses are not that close. Then we have the rare causes like the hemifacial spasms and such things. So my take home message is always listen to the history, and most importantly in this case it was happening every time after the child woke up from the sleep. Thank you.
Thank you, Dr. Nirmal, for for an eye opener. Actually, even though the child was closing the eyes, it's an opening for the ophthalmologist. And I think that is. Should we leave the discussion to the end, or we can have it as an. So especially in a recurrent corneal erosion, I myself am a personal. I have a personal experience with recurrent corneal erosion. I had recurrent corneal erosion in my left eye, and I had it for around 5 years.
Okay.
So it is very painful, and unfortunately when you see the patient at 10 a.m. in the morning, nothing will be seen most often. So a video is very valuable in most of these cases, I feel. And even in facial tics, it's very important to have a video. So even if we refer to the pediatrician, I usually advise the parent to take a video and then show it to them, even if they don't we don't see it very often. Sometimes we don't see that patient having that problem during our examination. So it's an eye opener.
No, many a times what happens is when the pediatric ophthalmologist, when they don't get the diagnosis, they end up doing an EEG. The EEG might sometimes come up with something, and the child is started on anti-epileptics. So I think the history part is very crucial, and we live in a time period where we are more taught to talk more and listen less. I guess when it comes to our specialty, we need to
Yes,
listen more.
exactly. Yes.
So I have a good. Do we have to send to pediatric neurologist in all the cases if no other factors are there, like no other drive?
Usually, what I do is most of them will be having some element of allergic
Yeah,
conjunctivitis.
we
So
treat that, but
usually,
if still it's persisting, do we have to send all to neurology evaluation, or
if I am suspecting tics, actually, usually I send because it might lead behavioral therapy, and especially when we are suspecting tics, it is always better to ask for vocal tics also. So that could be pointing towards Tourette syndrome. So nowadays, tics is becoming more and more common, and sometimes they have this eye rolling movements. That is what the parents say. He's doing like this, like that, and all sometimes. So if at all I don't find any cause as such, and if I feel it is tics, then I send for a consultation.
I totally agree with
One more thing I want to tell. I am one of the older generation ophthalmologists. The history is very important. What you said is very good, which is lacking nowadays. Many people don't take a proper history. So a proper history from a very good observer, especially the mother, in case of children, is very important. That is one point you have struck.
Mother, sometimes it is made nowadays.
Yeah, who is very
So
observant and
I ask her, I ask
usually
who is sending maximum time with the child.
yeah, that is very important, and that is one good thing that you have stressed. Very good.
as a pediatric ophthalmologist, we usually don't get a history from the children at all. So, whoever is a bystander or whoever is a caregiver, I think that is one very relevant point that you need to take a proper history from them and rely on that history also. It's not enough that you take the history because we are always doubtful whether they saw it correctly or not. Because recently, the same kind of a scenario I also had. The child turned out to have autism. And it was they just came with tics and with just head tremors, and you need to keep observing the child. It may not be only the tics, I mean the blinking that you're seeing. There may be slight head movements or motor movements, so they may be just motor tics. They may present with motor tics but may have underlying an autism long.
Excess screen time is another important
Yes.
factor nowadays. The children who are watching too much of TV, mobile, they end up developing this frequent blinking, and most of them don't have anything else. And if you ask them to stop for a couple of weeks, most of it dies down. So we can try for a conservative, wait and watch kind of attitude also. We can take maybe maximum for a few weeks or a month at max. But beyond that, if it is persisting, and sometimes what happens, the child has had a recent change of school or change of situation, a close friend has gone to another place, or I have seen such cases also, and they suddenly develop all this tics.
More of a behavioral or stress related response that you see in children. But I think even if you don't have a pediatric neurologist at hand, I know that you have a readily accessible
I have a
pediatric
very good
neurologist.
pediatric neurologist.
So if you even if you don't have that, what I feel is a pediatrician who is sensitized to these sort of patients, because everybody may not be sensitized to these aspects. So if it is that is available, then that's also a good option.
Neena ma'am, your comments on this?
Usually, because we are seeing the child for a very short duration of time, and I usually ask the parents to record the eye movement videos at home, because that's a very good thing, because you may pick up some unusual movements in the videos which you may not notice in your OPD. So, as you said rightly, we don't label anything as idiopathic or tics unless you get a neurology opinion. So, you rule out all ocular causes, including, dry eye, other conditions of blepharospasm, allergic eye disease, refractive errors, everything you rule out. And if you're not able to pinpoint it, and the parents are definitely worried, that's where they're coming to you. So we don't brush aside anything as idiopathic unless we get a neurology opinion, because some of the kids would have underlying seizure disorders or some other, conditions, autistic, ADHD, but we are not the ones to diagnose them as such. To get an opinion from a specialist, because definitely it's what we have to do is we have to treat the patient and not the disease. So what the disease is will unfold as we treat the patient.
Another important thing is many of these a little bit older children will be having allergic rhinitis, and they do all kind of things with their face. Even I am someone with allergic rhinitis, and whenever it is severe, I do all kind of things. My face, I close my eyes like this, do things like this. So many of the time they think the problem is with the eyes, but if you ask a proper history, you will know that it is allergic rhinitis, and when that is treated, all this grimaces will disappear.
So it could be like, that's tics can happen it can be any sort of tics. But then before we say it's just tics and, it is just attention seeking behavior, we must rule out all organic pathology.